Hello, everyone, and welcome to day 3, the last day of CMNCP22, the annual conference of the Canadian Municipal Network on Crime Prevention. My name is Audrey Monette, my pronouns are she, her, and I'm the Director of Projects and Research for the Canadian Municipal Network on Crime Prevention. Before we get started today, I do want to acknowledge that I'm joining you from the traditional unceded territory of the Algonquin Anishinaabe Nation, colonially known as Gatineau, Quebec. I want to thank you all for joining us for this year's conference, and I'm very pleased to welcome everyone to this session that is titled Reimagining Mental Health Crisis Response, Examples of Non-Police Initiatives in Canada. As you may have seen on the conference program, we had planned for Dr. Jamie Livingston from St. Mary's University in Halifax to moderate the panel, but due to a family emergency, he's no longer able to be in attendance. So I'm going to start by providing a little bit of context to set the stage for the conversation, and then I will introduce our amazing panelists and we will dive right into our presentations. So the panel discussion today is going to focus on non-police mental health crisis response in the context of community safety at the local level. And we know that police are often the default first responders to mental health crises in most communities in Canada and across the world. And that can result in reduced help seeking for mental health services, criminalization and stigmatization of people with mental health issues, violent and fatal interactions, and a very heavy burden placed on police. So increasingly, communities are advocating for new approaches to crisis intervention that are community-led, that are trauma-informed, and that are alternatives to police-involved crisis response services. So recognizing that mental health crises are health issues and are not criminal issues, these initiatives respond to people experiencing mental health crises without the police. So using trained mental health crisis workers, including people with lived experience, and so on and so forth. And the goals of these approaches are really to minimize police involvement in mental health crises and to provide services that more effectively address the health and social needs of people in crisis. So this session today is going to center the voices of service providers as well as researchers to explore various models or approaches that are being implemented across the country. And you'll see that each of our presenters are at different stages of the planning or the implementation process or just local conversations on this topic. So you'll have an opportunity to hear about some of the learnings, the challenges, the successes from various perspectives and various initiatives that are at different stages from coast to coast. For those of you who are interested, I do also want to mention an initiative that Dr. Livingston is working on, which is a web resource that's called justmentalhealth.ca. I'll post it in the chat in just a minute here. And that website is basically an interactive map that documents programs from across the world that do provide civilian mental health mobile crisis services. So programs are categorized into 6 types based on their staffing model or composition. So those categories include programs where staff are clinicians, medics, crisis workers, peers, as well as community members or volunteers. So I do encourage everyone to have a look at the Just Mental Health website if you are interested in learning more about some of those different models that exist here in Canada, but also all across the world. So with that said, let's dive right into our session. So we have about 90 minutes for this session this morning. So each presenter is going to speak, and then we'll have time for questions at the end. And we are going to keep the Q&A until the end just to make sure that each panelist has sufficient time for their presentation. That being said, though, if you do think of a question for any of the presenters throughout the session, feel free to post those in the chat throughout, and we'll be monitoring that, and we'll pull some of those questions from the chat at the end. So without further ado, I am very pleased to introduce our first speaker, Claire MacDonald. Claire is the 24/7 Crisis Diversion Program Manager with Reach Edmonton Council. Since coming on board with the 24/7 Crisis Diversion Program about 2.5 years ago, she's been really working on strengthening the program collaboration, enhancing protocols, developing and managing a new data collection system, and of course, navigating the pressures that COVID and the opioid overdose crisis have put on that program. So Claire, thank you so much for being here. And without further ado, I will hand it over to you.
Okay, so I first want to start. Thank you for having me here. I want to recognize that I'm joining you virtually from Treaty 6 territory and home of Métis Settlement 4. And I'm grateful to all of the love and care that many of the First Nation, Métis, and Inuit have given to this land and to all its people. And that's granted me the privilege to work, play, and live here. So I am going to talk about the Crisis Diversion Program. It is a non-emergency mobile response that's been operating in Edmonton, Alberta since 2015. So a primary outcome of our initiative is to reduce and divert inappropriate 911 calls away from emergency services and connect vulnerable individuals to the resources that are better equipped to meet their needs. So a bit of history about our program. Back in 2008, then Mayor Stephen Mandel created a task force on community safety, and the task force developed the REACH report, which outlined 9 recommendations for safety and well-being in our city. Recommendation number 4 was for a 24/7 service delivery model for high needs populations. In 2010, the REACH Edmonton Council for Safe Communities was founded and tasked with implementing the 9 recommendations outlined in that report. Between 2010 and 2012, there was extensive community engagement that took place that assessed the needs of the city and informed the development of a request for proposal for a 24-hour system that helped with navigation to services. This was facilitated by REACH Edmonton. So in 2012, REACH Edmonton and Homeward Trust, which is a housing organization here in Edmonton, released a request for a proposal to develop and operate a 24-hour system to divert at-risk citizens or chronically homeless individuals during episodes of inappropriate engagement with emergency services. This was an open RFP, and several community agencies submitted proposals, and one was selected. So in 2012, the Mobile Assistance Program, or MAP, was launched and responded to referrals primarily from police at the time. And they also conducted outreach to provide rapid response and complex case management, and also follow up with the community members they were working with. The goals of that program were to increase permanent housing placements for vulnerable people through Housing First, and decrease the number of cases, hours, and dollars spent by police and other emergency services for the vulnerable population. So after operating for 2-ish years, the discussions began about the 24/7 MAP program. So really focusing on the results, the outputs, the efficiencies, and ultimately the outcomes. And they conducted an environmental scan of other relevant resources in the city that might be offering those services. It was determined through that process that in order to scale up 24/7 MAP to meet the demand of the calls from emergency services and doing that outreach work to address homelessness would cost a substantial amount of money every year to do both. So this led to further community engagement sessions to discuss interest, feasibility, and logistics of a different integrated crisis response that focused more on diverting inappropriate emergency service calls rather than the housing and case management, as there were other services in Edmonton that were doing that work. So in September of 2015, the folks that were operating the 24/7 MAP, the agency, decided to move more into housing and placement, and the MAP program ended. So the next month in October, the 24/7 Crisis Diversion Program launched with new partners. So here are our partners and who we work closely with. So 24/7 Crisis Diversion is a collaboration between REACH Edmonton, Canadian Mental Health Association, which operates our dispatch line, Hope Mission, and Boyle Street Community Services. Each of our partners are large nonprofit organizations and provide a variety of services to Edmontons experiencing conditions of vulnerability, and that also includes crisis diversion. So Boyle Street Community Services has been operating in the inner city since 1971. and offers services like a large community drop-in center, family and youth support services, housing support. They also have a social enterprising program that provides low barrier employment opportunities. Hope Mission, among other things, there's many other things that they do, but that's just some of the key points. Hope Mission has been operating since 1929 and is the largest shelter system here in Edmonton. They provide overnight shelter, transitional housing, addiction and treatment services, recovery, youth programming, and they're also the main meal service provider, offering 3 meals a day to anybody in need. The Canadian Mental Health Association is more well known across the country, and they provide and operate the 211 information and referral line here in Edmonton. And they work to navigate the complex network of social services to help callers access the resources that they need. And then Reach Edmonton, who I work for, is the backbone support to many community strategies in the city. And we work with community partners to develop collaborations that make Edmonton a safer and more vibrant place to live. And so we also work closely with our Edmonton Police Services, Alberta Health Services, our city's peace officers as well. And we are solely funded by the City of Edmonton. So a little bit about the governance of our program. We are guided by leadership from different levels, starting at the steering committee. This is made up of senior leaders of our partner agencies, along with leaders from our key stakeholders. They meet quarterly, more recently a little bit more often, but they usually meet quarterly to review program efficacy, strategies, challenges in the city within their own organizations as well. Our operations team is made up of managers and supervisors from the partner agencies who operate crisis diversion. They meet weekly or bi-weekly, really depending on the time of the year, to coordinate the practice at the operational level. These meetings offer opportunities to troubleshoot challenges, update procedures and protocols, and really maintaining that open communication amongst the partners to ensure the relationship is strong as well. The operations group oversees the frontline practice directly, and frontline staff are engaged through collaborative trainings, retreats. We do staff surveys to gather their feedback and suggestions, and then communication flows up to steering from frontline and back down from steering to frontline on a regular basis through that operations team. Lastly, we also have a working group, which is made up of key stakeholders in the city whose practice overlaps with crisis diversion. This group acts as advisory for crisis diversion practice. It identifies collective issues that we are seeing in the city, gaps in service delivery within the city. It offers an opportunity for collaboration and fosters shared understanding of the current community context that we're all working in. And so all of these levels help to enhance program practice. So 24/7 Crisis Diversion is the only publicly accessible team that can support community and business 24 hours a day, 7 days a week. So that means anybody can call us for support for vulnerable folks in the city. They're able to do this through the 211 Press 3 phone line. In 2016, we launched a social media campaign to inform the city about the crisis diversion program. This media focused on when to call 911 and when to call 211 to access crisis diversion. It was a hugely successful campaign that led to citywide knowledge of an alternative option to calling emergency services. So currently at a 211 level, over 70% of our referrals come from private citizens and businesses and community agencies in the city. Just recognizing that that campaign worked and people know who we are. Emergency services have a direct link to our mobile teams that they can contact us for support without having to go through the 211 line. That's fire, police, EMS, and our peace officers all have that direct link to our mobile teams. Out of the emergency service calls that we receive, or those direct referrals, over 70% of those come from EMS. So as a result of our capacity barriers, which I'll talk about shortly, we still triage every call that comes into the program, whether they're from emergency services or from our 211 Press 3 line. We look at the needs and the risks involved in each request, and those who are at greater risk to coming to harm without intervention, we will go to those calls first. Our program responds to calls for support for individuals who are likely to come to harm without some sort of intervention. They're often folks who are experiencing mental health or medical non-emergency crisis, and they're often folks who are intoxicated or otherwise impaired. Our teams offer many levels of support with the folks that they engage with, and it really starts at that 2-on-1 level. So the operators will triage the calls, and if crisis diversion isn't the right response, then they have a multitude of resources that they're able to provide to callers to help meet their needs. At a mobile team level, our staff go out to dispatch calls. They try to determine what type of support the individual might need, because a large portion of our referrals come from the general public and business. The need that they identify might not always be the need of the individual when we arrive on site. So for sometimes that results in a need for supportive transportation. So for those who need supportive transportation and request it, our teams will provide that, whether it be to a formal agency or to a hospital or even to their private residence. And when we transport folks to a social service agency, we really aim to connect them with those services by walking them into the building, helping ease that intake process, being able to pass off important information about the individual, just to build that relationship for them. The emergency shelters are the main resource that we take folks to, and it's primarily because it's the only thing available, especially after hours. It represents about 80% of our warm handoffs within the city. Throughout the pandemic, our teams worked to support the COVID transportation needs of our vulnerable folks. We did notice there was a large gap in service for our folks that were presenting with COVID symptoms or were COVID positive. There was no other availability for transportation to the sites that they needed to go to. And so during the thick of COVID, we provided over 1,200 COVID-related transports. One of the challenges that our team runs into is the lack of available spaces to take folks to meet their presenting needs, especially in cases of complex needs. Unfortunately, shelter is often the only thing available, and we are seeing folks who are beyond the level of care for our shelter system, but also not at a level of care needed to be admitted to hospital. So that creates pretty significant barriers for accessing appropriate services in moments of crisis, but our teams work really hard to navigate those barriers the best that they can for the individual. So our program operates 24 hours a day, 7 days a week, 365 days a year. Our Hope Mission partner operates in decommissioned ambulances, and our Boyle Street partners operate in Dodge Caravans. Our teams don't carry any weapons. They don't have any kind of tactical training. They're really armed with the power of relationship with the folks that they serve. It's about building that relationship and building the trust to help them access what they need. Our vehicles don't have safety equipment or safety barriers that separate them from the folks that they're transporting. So we're unable to transport folks who are overly aggressive or violent, just to ensure safety of both everybody who's in the vehicle. We also aren't able to force folks to leave anywhere or force folks to come with us, which 6% of our referrals to 2-on-1 so far in 2022 are requests to remove folks from property. We provide service education to those callers and say that's not something that we can do, but we go out and we try to work with the individual to see if there's any way that we can support them. But it's ultimately up to them whether they want to accept the support. So one of the biggest challenges that our team faces is meeting the demand for support with only a small fleet of vehicles. Hope Mission and Boyle Street both operate 3 vehicles each during a 24-hour period, but they are not on the road at the same time. So between 3 p.m. and 1 a.m., we do have 4 vehicles in total on the road to support the entire city of Edmonton. Between 1 p.m. and 1 p.m. and 3 p.m. and 1 a.m. and 3 a.m., we have 3 vehicles in total on the road, and the remaining time we have 2. Which makes it challenging to meet the demands of the entire city, especially during events of extreme weather. This winter, we were able to move some things around, and we will be adding 2 additional shifts during the winter months from November until the end of April. So we'll have an additional 6 a.m. to 6 p.m. and 6 p.m. to 6 a.m. Team on the road. So our team members are deeply committed to working with individuals who have complex issues that don't always easily resolve. Our staff come from a variety of backgrounds in education. There's no specialties that we require on the teams, but our staff are well equipped to support the system navigation needed to connect folks to the resources that they need in the moment. While working with the team, we provide training upon hire that you can see on the slide, but we also provide additional training to help support the work that they do throughout the year. So we collect an immense amount of data, and we have for a really long time. From 2014 to 2020, the crisis diversion mobile teams used the 24/7 Edmonton app. This was designed specifically for the program and ensured privacy through encrypted data and secure platforms. It tracked time of engagement, number and location of contacts, and it also integrated with efforts to outcomes, or ETO, which is the system that many of our housing organizations use here. And it helped to support frontline workers in the field. It also offered an internal dispatch system, which made it easier to send out the dispatches to all of our teams. Sadly, in 2020, the app crashed, so we had to look for an alternative option for data collection, and we started using the Esri ArcGIS system, specifically the navigation and dispatch and survey 123. It didn't take long, though, for us to recognize that this system did not provide the frontline staff with the needed information to do their jobs in safe and informed ways. So we started researching another option. In 2021, we moved to a Microsoft platform, and we are using the Power App system for the mobile team response. This has allowed staff to have all of the real-time information that they need, as well as a comprehensive dispatch system that they use as well. Data is updated in real time into the 24/7 dashboard. So we're able to provide up-to-date data for service providers, business improvement areas, city initiatives. And we use our data to make data-driven decisions, and both within the program, but also system-wide. And so we are able to pull those geographical data points as well, and it was really helpful in the field. So just a bit of stats from our teams. Last year, so 211 itself responds to about 75,000 calls in Edmonton every year, and only about 25 to 30% of that come through on the crisis diversion line. So currently we don't have any dedicated staff who only answer crisis diversion calls. However, we're hoping in the new year to move to a system where that's possible. So where we only have representatives who answer crisis diversion calls, because there's been a noticeable increase in demand for our program. Last year, 211 answered just under 30,000 calls for support on the crisis diversion line, with peak call day seeing 133 calls. The program aims to answer calls within 90 seconds, but times of extreme weather or other things that might be happening throughout the world or this city increase the call volume at a 211 level. At a mobile team level, last year, our teams accepted just over 17,000 dispatches, so whether that be from 211 or from emergency services. We also conduct what we call general support, which is proactive engagement that focuses on preventing possible crisis escalation. So whether that's program downtime in between calls, just when they're around and they see folks outside, they'll stop and have conversations with them, see if there's some sort of support that we can provide to them in that moment. And those really help to help with the decriminalization of poverty and mental health and addiction by reducing engagement with emergency services. So when we combine those two types of contacts, we engaged with folks just under 37,000 times last year, and we've already exceeded that where we're at now in this year at 39,000. So in the past 4 years, crisis diversion demand for our program has increased dramatically. So from 2019 to 2021 alone, there was a 64% increase in the responses to events by our teams, which really demonstrates a crucial need for our program. Our program is funded through the City of Edmonton to respond to up to 1,200 calls per month, and that's just the dispatch calls. But in the first 10 months of 2022, there was all but one that exceeded that target number set by the city, and it came in at 1,196, so just about 1,200. So the demand for service is consistently exceeding our program's capacity. So earlier this year, 2 of our city councillors put forward a motion to substantially increase the budget of the crisis diversion program, recognizing that it is a needed service within the city. And so following debate, council asked us to put forward a budget and a business case to support the need for increasing our operating budget to meet the needs in the city. That's been submitted at the end of this month. It'll be formally presented to City Council, and hopefully from there it'll be approved and we can move forward with increasing our capacity. So what we're hoping for is moving to having 12 dedicated 211 representatives who only answer crisis diversion calls. We're hoping that that will reduce our response times at a 211 level to answering 80% of calls within 30 seconds. And then we want to incrementally add 3 additional mobile teams each year over the next 4 years in hopes to be able to reduce wait times for our teams to arrive on site and also increase support geographically throughout our city with having more presence. We're also helping to build in winter emergency response because every winter we know that there's an increase in demand. So having those additional teams on the road will be super beneficial. And then also yearly program evaluation to ensure that we are improving our efficiencies in practice regularly. So just a big thank you to all of our frontline staff who without them, this wouldn't be possible, and the folks in our city wouldn't have access to the services that they need in the moment that they're experiencing them. So happy to answer questions later on, and you can reach out to me anytime if you're looking for more information.
Thank you so much for that, Claire. I think it's so interesting to hear this presentation again, because I actually heard a presentation on this program probably 5 years ago, and it's so interesting to see how it's still evolving and responding to new and emerging needs. So even if it's a program that's been around for a while, it continues to grow and continues to change over time, which is really great to see. And excited to see sort of where it goes next in terms of building that capacity and that geographic capacity as well. So thank you so much for that. So I think we'll move to our next presentation. So it's my absolute pleasure to introduce our next speakers, Amil Davis and Racquel Hamlet. Amil is a policy development officer in the Social Development, Finance, and Administration Division of the City of Toronto. He's a member of the city's Policing Reform Unit, which oversees the implementation of City Council's decisions on changes to policing in Toronto adopted in 2020, including the development and implementation of the Toronto Community Crisis Service. And Racquel Hamlet has worked with TAIBU Community Health Centre for the last 12 years as a registered social worker and therapist. And more recently, she's now the manager of wellness and community crisis response. So Amil and Racquel, it is so great to have you here with us to discuss the Toronto experience with this new community crisis response service. So I will bring the slides up and the floor is yours.
Thanks for inviting us to share a little bit about the Toronto Community Crisis Service pilots. In 2020, Toronto City Council adopted 36 decisions on changes to policing in the city, and the development and implementation of alternatives to police response to mental health and substance use crisis came out of those decisions. And at that time, the world, including Toronto, was experiencing mass mobilization against police violence, which was a watershed moment for action in the city following years of activism and advocacy from residents, community organizations, and mental health experts. So for much of 2020 and 2021, the city, in collaboration with a wide range of stakeholders, worked to develop the Toronto Community Crisis Service pilots. So the Toronto Community Crisis Service pilots provides a non-police response to non-emergency calls from people experiencing a mental health crisis and requests for well-being checks. The service is community-led, and it's anchored by 4 partners in 4 regions of Toronto. The pilots were launched in the summer and spring of this year and will operate until 2025 with the hopes of scaling citywide in 2026. The City of Toronto adopted SAFETO, which is its community safety and well-being plan, and the Toronto Community Crisis Service pilots are a key priority of the plan. So just for a high-level overview of how the pilots work, the pilots were designed to have a non-police central intake channel, in addition to 911 being an intake pathway. 211 is currently providing that service for the pilots, and they're the ones who dispatch the mobile crisis teams that are a key feature of the pilots. The pilots are anchored in a community health service providers that are responsible for the day-to-day service operations, such as hiring and managing the mobile crisis teams. They provide the follow-up case management and referral services, in addition to other wraparound supports to service users. The staffing complement for the crisis team managed by each anchor partner varies. The anchor partners determine the staffing models that best suits the community that they serve. But some of the roles that are included in the crisis teams include case managers, service navigators, nurses, peer support workers, outreach workers, in addition to others. And at least 2 crisis workers respond to crisis calls. The city plays the role of funder and administrator for the pilots. It's responsible for providing backbone support for the service, in addition to leading intergovernmental advocacy efforts, developing and implementing public education campaigns to inform residents of the service, and identify areas for increased community investments. During the development of the pilots, we've heard from community that there is a need for mechanisms for community to provide ongoing input during the implementation of the pilots. So we established a citywide community advisory table made up of mental health experts and people with lived experience and other internal city partners to provide ongoing strategic guidance throughout the implementation of the pilots. We also have a third-party evaluator for the pilots, and the Provincial System Support Program at CAMH is leading the monitoring, evaluation, and knowledge mobilization for the pilots, and they're working to produce a 6-month report that will be published that will detail some of the outcomes so far of the pilots. So this is a snapshot of some of the key service offerings for the pilots. The pilots provide 24/7 service, and it's strictly voluntary and consent-based. The mobile crisis teams do not coerce, apprehend, or evict anyone, much to the dismay of some of the people who call in to request the service, but we do well to maintain a client-centered focus in the service. It also has a no wrong door approach, allowing people who requires the service to have access through multiple channels. And it provides services to Torontonians aged 16 years and over through a trauma-informed and harm reduction approach. It also offers the mobile crisis teams, as I mentioned before, that provide immediate crisis stabilization and supports, and provides post-crisis follow-up and case management for those who require it. And also importantly, the pilot have referral networks that avails service users of culturally relevant supports. The pilots are operational now in all 4 of the selected pilots regions in the city. The pilot boundaries correspond with the Toronto Police Services divisions, and they were chosen based on Toronto Police Services divisions with the highest number of person in crisis calls, the highest number of apprehensions under the Mental Health Act, and the highest number of responses by the mobile crisis intervention teams, which are a part of the Toronto Police Services as well. We also looked at areas of the city that have the highest needs for mental health supports. So our pilot adopts the anchor partner model. So it's led by 4 key agencies in the 4 pilot regions. In the northeast region of the city, the TAIBU Community Health Center leads the pilot, and they adopt an Afrocentric approach to providing services to those in need. In the downtown east, the service is anchored by the Gerstein Crisis Center, and they are a mainstay in community-led crisis response in the city. They've been doing the work for over 30 years. And in the downtown west, we have an Indigenous-led pilot that is anchored by the Two-Spirited Peoples of the First Nations, and they do take an Indigenous approach to providing services, mental health supports to those in need. And in the northwest of the city, the pilot is anchored by the Canadian Mental Health Association, and they adopt an anti-racist, anti-oppressive, and culturally safe approach to providing services. All of the anchor partners bring with them an extensive network of partners that they refer service users to if they need additional supports after the immediate crisis intervention. So we chose 211 as our non-police intake channel. Part of the reasons we chose them is because it's already a well-established, well-known number. It's also easy to remember. They provide 24/7 coverage throughout the year in multiple languages. And they have a track record of answering a high volume of calls for supports. They also have a wide number of in-house supports that they provide, and referrals, a wide referral networks for support services for service users. So in addition to operating the non-police-led crisis response pilots, the city engages in intergovernmental advocacy, because in doing the work, we do realize that we need to build up a more robust mental health support system, of which the Toronto Community Crisis Service is a small part, but much needed part of. So we are working to identify the required investment throughout the implementation of the pilots, and to provide further updates to Toronto City Council on the magnitude of investments that are required. We're also engaged other partners to identify further investments needed to scale up evidence-based mental health supports, including investments in safe injection sites, managed opioid programs, crisis beds, and other housing and supports for people who are homeless. I'll now turn it over to my colleague Racquel to give an overview of the Toronto Community Crisis Service pilots being anchored by the TAIBU Community Health Center in the northeast of the city. And we'll happy to field any questions that you may have about the pilots at the end of the presentation.
Thank you, Amil. Is a great overview of just like the backbone of how the program works. So I'll just give a little bit of information on our day-to-day and kind of how things go in terms of TAIBU itself. So next slide, please. So TAIBU CHC, we were established in 2008. I joined the team in 2010. At that time, we had probably about 10 staff members, and now we have staff of 95 people. So it's been quite a lot of growth over the years in doing mental health services in the Malvern community, in the Scarborough community. So we offer primary health care, mental health support, social services across the GTA. So anybody that is from the African diaspora, regardless of where you live in the GTA, we will service you. And specifically, if you live in the Malvern area as well, it doesn't matter your ethnicity, as long as you're in the priority population, we'll service you. We also work with clients that are undocumented, essentially the clients that no one else will serve. TAIBU will take them in. I think the only people that we're not allowed to service are visitors to the country. So as long as you can show us that maybe they're here and they overstayed and they don't plan to go back, we will service them and find a way to get them the healthcare that they need. So with the Toronto Community Crisis Service, it's probably the largest expansion that TAIBU has had in terms of programming over the last 14 years since we've been here. So it's added quite a bit to our portfolio in terms of what we're able to do now in regard to crisis response, because it was always a gap for us in needing crisis response, needing something for people in crisis and not having it. So it's been quite a gift to our CXC so far. So in terms of how we work, how we do things at TAIBU, everything is culturally responsive. Everything is from an Afrocentric, anti-oppressive, anti-racist lens. From the very beginning, all the things that we do when we try to, come into a situation, every client that comes in, we don't look at them as, okay, this is somebody with, with diabetes, or this is somebody with depression. Well, let's, grab our book and do what the book says. We try to take it from the place of, where is this person from? What are they possibly experiencing culturally? What are some of the cultural nuances that are going to inform how we treat them? So, we applied the same principles to the Toronto Community Crisis Service to make sure that the clients that we were going to be seeing, that our staff was going to be reflective of the population that we were going to be serving. So immediately that brings, a certain sense of commonality between clients and the service providers that we have. So again, the guiding principles are really, really important for us in terms of how we tackle the work and making sure that that is the backbone that we go in with, that we're not necessarily doing things from a Eurocentric space, but we're making sure that we're looking at each client as an individual and what is that client bringing to the table that we can try to meet them where they're at. And that's a big part of the crisis service. So it's not always about, are we going to transport them to hospital or this person needs to be formed. It's about, where is the client and what is the client saying they need at this point. And these are all the other pieces as well in terms of language. We definitely make sure that on our team, we're very fortunate to have one staff member that speaks 5 languages. So everybody loves when he's working because we have no issues at all. We have a couple of other staff that do speak French, Urdu, Tamil, and that's generally the population that we serve. Huge focus on the social determinants of health, because a lot of the times the cases that we're going to, the people that are in crisis, it's not just because they have mental health concerns, it's because, they don't have food to feed the family. And so the mental health is exacerbated, right? They don't have appropriate housing, so mental health is exacerbated. So really trying to look at things from that perspective. And one of the most important pieces is this point about nothing about us without us. So we've done a lot of work to make sure that the community is involved in everything that we're doing. Trying to make sure that we have members of the community that sit at a table, which is our community advisory table, to let us know, within the service, this is what's working, this is what's not working, this is what we like, this is what we don't like. So trying to consistently, tweak it so that the community is happy with the services that we're giving and they feel like we are being inclusive of their needs and making sure that their needs are being met. So sitting at our collaborative table are these agencies. So we have the Scarborough Health Network, which is actually a merge of 3 hospitals, I believe, within Scarborough. And so we have a psychiatrist and the director of the hospital that sit at the collaborative table, and they offer insight to us all the time in terms of ways that we can improve the program, things that we can do. Very early on, we identified that psychiatry was a big piece that was missing from the pilot, the way that it was set up. So one of the psychiatrists on the table, he actually said, you know what, he would be willing to give us one of his psychiatry students to offer a consultation. So the team actually gets an opportunity to, call the psychiatrist if there's something that's come up that they're not sure how to deal with, or, just needing a little bit more support, or there's somebody that has a psychiatrist but can't see them for another 6 months and needs a med review now, or that sort of thing. So we've been gifted a psychiatrist through our collaborative table. Scarborough Center for Healthy Communities is another community health center not too far from TAIBU. They also offer culturally appropriate services. So sometimes we meet clients that need a doctor or need some services that we can't necessarily offer. So SCHC is happy to expedite that service and help us to enroll clients at their center. CMHA Toronto has also given us a crisis bed. So a lot of times we're meeting people that don't have a place to live. They're very transient. They're kind of couch hopping, they're shelter shopping back and forth. And so sometimes if we're able, if the crisis bed is open, we're able to put somebody in there for 30 days, and at least get them connected with case management, caseworker, and try to figure out some stable housing for them. So all of these agencies that sit at this table, they're integral to the success of the program because they bring elements that I may not have, or that TAIBU only doesn't necessarily have those resources. Strides is more youth focused. Black Health Alliance helps with the governing piece and the policy pieces. So each person plays a very integral role to make sure that we're not leaving any pieces out as we continue to move through and develop the program. And so our approach at TAIBU has always been, if we're getting involved when somebody is in crisis, we're already too late. So we use the same kind of philosophy in doing the crisis program, where we're trying to do a lot of community engagement, prevention, early intervention. So on the days where we're not getting a lot of calls and maybe, we're just kind of doing notes or paperwork, we do send the workers out. So it's 2 people at a time on shift. We send them out to do outreach in the community so they can hand out flyers and let people know who we are, what we do, how you can access, and possibly just accessing TAIBU for regular services. So in saying, if you don't have a doctor, if you need, foot care, if you need mental health services, or you have a youth that needs support, so promoting all of that stuff so they know that there's somewhere they can go, so that when they are in crisis, they're already connected to us. So it won't be, I'm having to now access a service that I've never used before. So we're doing a lot of community-based engagement, a lot of presentations, outreaching to churches, neighboring schools, other agencies, Children's Aid Society, so all the places that we know may potentially use TAIBU or the crisis service. That's kind of where we try to start. So then, next step is then the crisis intervention. So we try to wrap all the services around that we can. So we always refer to TAIBU as the one-stop shop. So you might come there for, a doctor's appointment, but then you end up getting your chiropractic appointment, there's yoga, there's lunch, there's all kinds of things that you end up getting when you come here. And that's the approach that we wanted to make sure that the crisis service has as well. So when we send out 2 workers to address a crisis, yes, they address the crisis. They try to see, are there supports for the individual person? Are there supports for the family that we can give? And there's always a follow-up call either the next shift or the next day to check in to say, okay, the crisis itself has maybe been dealt with at the moment, but are there other pieces that we can assist with? Do you need to be connected to post-crisis case management so that we can work on some of the larger issues, whether it's food security, housing, getting connected back to their doctor, or whatever it might be? So again, always trying to make sure that people are not left without the services that they need. And sometimes it does mean, that extra outer layer, so specialist services. So getting more information in terms of housing, maybe hospital supports, whatever it is that they might need. So this kind of the model that we work from inside out to make sure that clients have what they need going forward, and so that they don't continue to repeat the in crisis at the hospital home, in crisis at the hospital home, and continue that cycle. We're definitely trying to break it as best as we can. So I think I've spoken about most of the things here in terms of the languages, in terms of the languages and the different partners. One of the things that's really important in terms of our van, so we have 2 vans that we usually run 1 van. On Wednesdays, sometimes Saturdays, we might run 2 if it's busy. So the workers, they work 9 a.m. to 9 p.m., 9 p.m. to 9 a.m. It's 24/7. Sometimes we have an 11 a.m. to 11 p.m. shift that was to cover that busy time. During that time, the vans themselves, I think they're Toyota Siennas, wheelchair equipped. We do have a barrier in the back so we can transport people, if they're not necessarily in the best state. So we do a lot of transporting to the hospital. The van is very well marked, so people don't miss it. It's very visible in the community. So what we try to do is that if even we're just making a run to grab gas or something like that, people might see the van, and very often they approach it and say, do you guys have water? Do you have something to eat? Do you have something? So, it's not always somebody calling and saying, I'm in crisis, I need help. Sometimes, they just literally just need a meal. So we try to make sure that the van has everything that people may need. And as we get closer to winter, trying to stock the van with socks, gloves, blankets, things again that people might need, because we see people on the side of the highway all over the place. So really just trying to make sure that we're not only responding when we're getting dispatches from 211, we're also responding to what we're seeing in the community. So we will give, gift cards for Tim Hortons or MacDonald's or something for people that may just be on the road. And we also make sure we give them one of our flyers. So again, if they ever are in crisis, they know who to call, or they remember, that van that gave me a bottle of water. So again, trying to respond to the community as best as we can. Connecting people to culturally appropriate services, I think, is one of the biggest pieces of what we try to do. So it's not just, we get somebody, and so usually if we maybe meet somebody that is in crisis, maybe running from a violent situation, generally the place that we would send them would be the Barbara Schleifer Center, and that's where everybody goes for violence against women. However, it doesn't necessarily have culturally appropriate services for somebody that may be running from a refugee situation, and has now come here and is trying to start over. So we do look for very specific places that will suit the needs of the client, which does take a little bit more time, but it's proven that it works. So we really do try to set clients up with things that they will respond to culturally. And generally the calls that we go to would be people in crisis, wellness check, threats of suicide. Those are generally the ones I think our number one is person in crisis is what we respond to. So in terms of the pathways to care, so the biggest pieces in terms of what we respond to would be housing issues. So it's usually we're getting calls from the shelters to maybe deal with clients that are, not doing very well, having a bad day, need a little bit of extra support. Sometimes we're dealing with clients that are getting kicked out of the shelter because they haven't followed the rules due to, some mental health concerns. A lot of family supports for people with mental health stressors, loss of IDs, food insecurity, trauma counseling. So this is like a daily, these are the things that we're seeing. And sometimes all of these things appear in one person. So we're getting very, very complex cases. It's not simple stuff that you can just deal with, in half an hour, and then we're good to go. Sometimes the team is with one person for 4 or 5 hours because it's taking time to build that relationship and do the things that we need to do for them. So our top referral places would be sometimes PSW support, sometimes it's they need to connect to a doctor, food supports, trauma counseling. So we're building a very robust resource list to make sure that we have the resources to send people to. I guess that's it. So again, any questions that you guys may have at the very end to answer them. Thanks, Audrey.
Thank you both so much for that overview. And I think it's a fairly new pilot, but it seems like there's so much work that has gone into it already. And I think it's so powerful how it's so rooted in community. And I think even the language around anchor agencies, like the word anchor, just shows how anchored it is in community and how, the different pilots kind of serve different needs. And I think it's such a powerful model. So I learned a lot, and I thank you so much for that presentation. Maybe what I'll do is remind folks, participants, that if you have any questions for any of the panelists, feel free to post those in the chat. We have one more presentation, and then we'll have time for some questions at the end. So with that said, we'll move on to another presentation. So last but certainly not least, please welcome Tari Ajadi. Tari is a PhD candidate in political science at Dalhousie University and a pre-doctoral fellow in Black Studies at Queen's University. He's a board member with the East Coast Prison Justice Society and a co-author of the Defunding the Police, Defining the Way Forward for HRM report that was released earlier this year, January 2022. Tari, thank you so much for accepting our invitation to participate in this session. And I will hand it over to you whenever you're ready. Thank you.
Thanks so much, Audrey. Really appreciate it. And thanks so much to everyone, including all of the previous presenters. It's really been incredibly informative and interesting panel, especially because, you know, what many of the other presenters have been kind of showing us is the model for how these kinds of civilian mental health crisis response models can move forward. And that's what we're certainly myself and many of the folks that worked on the report are hoping to see in the future. So with that being said, I'll just quickly begin my presentation. So to start with, just a brief land acknowledgement. So I'm a PhD candidate at Dalhousie University, which is located in Chipuktuk or Halifax, which is in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which Mi'kmaq and Wolastoqey people first signed with the British Crown in 1725. And it's really important, you know, when we're thinking about the land in which Chipuktuk or Halifax is currently situated, to understand that the kinds of interventions that we're talking about here disproportionately are there to kind of address some of the effects of settler colonialism and also the entwined processes of slavery that have underwritten struggle inequities in these lands since that time and before then. So I think it's really important to reflect on why it is that these responses are so necessary. So a brief roadmap on my presentation. First, I'm going to give you a bit of a background on the Defunding the Police report, where it came from, you know, why we started it, what we did. I'll give you a snapshot of some of the data from the report, which is available on the website of the Board of Police Commissioners in Halifax. So you're free to read. It's 218 pages. So you know, curl up with a mug of tea and get settled in, because it'll be a long one. And they'll talk specifically about our recommendations about civilian mental health crisis response before talking about, well, what's next? You know, where are things moving to in Halifax, or where we hope things might move to. So the background for the report. There's really two key impetuses for the report that emerged in 2020. So the first was kind of a slow building but very salient outcry over the way that policing was being conducted in HRM specifically, right? So in 2019, we had the report on street checks, which identified those significant inequities in the ways that policing, particularly street checks, was unfolding in the municipality. And previously to that, we've had many other incidences of police violence and police brutality in the municipality. But on top of that, of course, in 2020, we have this broader global context where we're reevaluating the role that policing might play within our societies after the murder of George Floyd by Derek Chauvin in Minneapolis in 2020. And so the report emerges from a kind of building advocacy effort amongst community organizers, activists, academics, and others who decided to try and address what they saw as an unacceptable encroachment on civil liberties in the municipality. So it proposes an alternative model of community safety that is not reliant on coercive forms of state violence to keep community members safe. Right. And so it is something that is an aspirational and vision oriented report, but at the same time, it is action oriented, right? Like it's grounded in specific recommendations that can and ought to be applied in the municipality. And so it requires the Board of Police Commissioners in Halifax, the Regional Council, and the province, amongst many other actors, to take steps towards transformation. And so just to give you a bit of a timeline here, the initial emphasis around the report came from a July 9th, 2020 motion around creating a definition of defunding, which was passed by the Board of Police Commissioners. And initially, this definition of defunding was identified as police performing policing functions, non-police performing non-policing functions, and everyone being adequately funded to provide those services. But as a co-founder and member of the Nova Scotia Policing Policy Working Group, we thought that definition was insufficient and largely tautological. And so we pushed the board to try and move towards creating a community-grounded definition of what defunding might mean, and that definition also being accompanied with a community consultation process alongside, some robust recommendations for how this might actually operate in practice. So on March 8th of 2021, the board approved a terms of reference for a subcommittee to define defunding the police, and the subcommittee was put together of community members with lived experience and with engagements in broader communities in Halifax Regional Municipality who guided the work of the report. In June 9th of 2021, we had a public consultation session, which I'll talk a little bit more about in a moment. And then on January 17th of this year, we presented the report to the board. And so the subcommittee developed 36 recommendations for transformation, and they come under 4 key pillars. The first is reforms to police practices, oversight and accountability. And so these are mainly at the board level, since the board is responsible for setting police policy. And so those things include making those policies public, right? Like making sure that members of the public are actually able to present at board meetings, things of that nature. Then there were reforms aimed at detasking the police and retasking more appropriate community service providers. And so this is kind of the section where our work on civilian mental health crisis response really comes in here. So this detasking was just one of a set of suggestions about maybe taking mechanisms and roles away from police services and putting those in the hands of community organizations. There were legislative, regulatory and policy reforms intended to promote community safety, and then there were financial reforms aimed at tying police budgets to clear performance metrics and encouraging public participation in municipal budgeting. And so this is again injecting a kind of more democratic dispensation into police governance and particularly into police budgets, because we know that especially in mid-sized cities like Halifax, there is a zero-sum game as it relates to budgeting. When you put money in the hands of the police, that money does not go elsewhere, right? And so that zero-sum game is really important to understand and to have a facility for community to be able to navigate. And so getting to the data from the report, one of the things that we did was we conducted an online survey, and we did have 2,351 responses. We also held a public presentation session that was about 6.5 hours long. There were 19 presentations from the public, and there were additional 8 written submissions by community organizations. And we also did do a extensive consultation with the National Police Foundation, which is the union for the RCMP. National Police Federation, not Foundation, excuse me. So 56.8% of participants in our survey indicated support for the idea of defunding, while 43.2% did not. Support for defunding was much higher amongst women and gender diverse folks than amongst men. But the data from the survey was very clear in the sense that it was unclear, right? There were extremely divergent opinions and understandings of what defunding could mean and whether it should happen in the municipality. And so survey questions included: what does defunding the police look like to you? What would defunding look like in HRM? And what role do you think the police should play in Halifax Regional Municipality? But there was one consensus issue in that data set. And so the most mentioned words in our survey were policing, community, mental, and health. And so police involvement in mental health is the single most prevalent issue in the data. It was also the one thing that people on both sides of this conversation and both sides of this debate actually agreed upon. What they agreed upon was that mental health crisis response ought to be delivered by trained civilians who can better attend to the needs of people that they're serving. So I'll just give you a few examples of quotes from our survey, just so you can understand what people were saying about these particular issues. So one person who was very much opposed to police intervention at all in many spaces in our society, noted that police should not attend any calls related to mental health unless asked to do so by a mental health professional. If police are in attendance, they should take direction from the trained mental health professional. Another, who was focused primarily on the role that policing played in family law issues, noted that police are often involved in family law matters, custody disputes and child protection issues where it's often triggering and culturally appropriate interventions are not used. Police are not, in my view, the most appropriate resource to use for mental health calls. But now we have someone who does not necessarily believe that defunding should mean that we should take money from the police budget and was opposed to the idea of defunding overall. And so they noted that defunding the police, to me, does not mean taking money away from the police budget. The police need their funding to operate. Defunding the police, to me, should mean an audit of the policing job should be done and the types of calls they respond to. Defunding the police that should mean police stop going to calls such as mentally ill persons, non-injury accidents, property disputes, and then the city should be funding other services like mental health clinicians to respond to those types of calls. So even when we start to account for people that are against taking money away from the police, they still think that actually mental health clinicians should be resourced in order to address mental health needs, especially in crisis. Finally, another comment. So I'm not sure what HRP currently does for mental health related calls, but many larger departments in the United States and other places have created special training and dedicated mental health clinicians that attend mental health related calls with an officer. This is probably the biggest thing that feels bad when not done, because police are typically dispatched to these types of calls and are not trained to deal with potentially mentally unstable individuals who may respond negatively. EMS in this province is way too busy to handle these kinds of calls as well. So more funding on both sides could find creative ways of helping some of the most vulnerable that are not trying to end up in jail. And so what this data demonstrates is that the public have a very nuanced and clear understanding of what it is that they're seeking as it relates to crisis mental health response. They're seeking dedicated clinicians who can address these calls and address them with empathy and care in a culturally responsive and in a solidaristic form and fashion. And so this is what came out of our response, right? The present mental health crisis program in HRP includes a professionally supported mental telephone line and a mobile crisis team that currently operates in Halifax. It does have a mental health professional, a nurse, a social worker, but they're paired with the police officer at present. And so in our report, which, as I mentioned, you can find on the website, we conducted a jurisdictional scan and analysis of models to assess whether a civilian-only model would be feasible for the municipality. And as we heard in many of the other presentations today, it certainly can be. And so we did recommend that Regional Council, in cooperation with the Police Board and the provincial government to the extent necessary, should revise the mental health mobile crisis team model to ensure that mental health crisis responses are generally diverted to civilian-only teams. And this should also be explored for other social health-based emergency calls. And so this is one of the kind of core recommendations of our report and something that we're hoping does emerge in Halifax Regional Municipality. So what next? Well, you know, I'm the only one on the panel that's actually not affiliated with an agency or with a municipality. So it's been a lot of waiting, right? Like it's November. We're in January. It's been a lot of waiting, and certainly I'm not here to discredit the very hard work of municipal staff in Halifax Regional Municipality. And the municipal staff are not the problem. It's oftentimes the politicians, right? And so the barriers do include so slow-moving governance processes, especially at the police board level, and conflicts over jurisdiction, right? And I'm sure that this is not alien to many of you folks that do work at the municipal level, where resources are scarce and where ultimately a lot of policy initiatives are somewhat in part dependent on the province, right? But there are tendrils of hope. So there is an upcoming public safety strategy in the municipality, and so we're hopeful that this will produce some outcomes that would be beneficial as it relates to civilian mental health crisis response. So we're eagerly awaiting that strategy. There is a recognition, however, kind of superfluous at the police board level, that changes do need to be made. And more importantly, one of the things that's happened since the deep funding report was released, and certainly since we were writing the report, is that there is a far greater understanding at the community level about the scope of the challenges that are involved, right? People are really starting to get involved, get engaged. They were significantly more involved in the last police budgeting cycle than they ever have been before. And this offers us an exciting prospect and possibility of meaningful community engagement as it relates to these issues. And so, yeah, that's pretty much my presentation. Please feel free to reach out to me. And I'm looking forward to any questions you might have. Thank you very much.
Awesome. Thank you so much for that presentation, Tari. I think that data is so interesting to see how when you bring a community together to talk about a topic that can be quite polarizing. And I think it's actually very brave that HRM kind of said, you know what, there's all this conversation around defunding the police and what does that mean? Let's bring people together and talk about it. And then next thing you know, there's common ground that can lead towards, approaches to mental health crises that are less harmful and that are more appropriate, and everyone agrees on that, or most people agree on that. So I think that's so interesting to kind of hear about that data, and I'm very excited to see those next steps in HRM. It seems like you have a really solid foundation and recommendations for that. So I think that brings us to 12:30 Eastern time, which means that our time together is up. I could have used another multiple hours of conversation on this. So thank you everyone for your presentations, for the conversation, very insightful. I think it's really awesome to see sort of the different stages and what the process looks like to kind of having this idea, engaging with community and advocates, to implementing it, to having it run for several years and continue to revamp and to rethink it and to improve it. I think it's very inspiring to hear about all these models. So on that note, I want to say a huge thank you to Tari, Racquel, Amil, and Claire for being here, for participating, for presenting your expertise and your experience. Thank you to all the participants who tuned in for this presentation, who asked questions. Very, very interesting panel. And we look forward to seeing you at our closing keynote this afternoon. There's also a networking session coming up in about 15 minutes, so we'll hope to see you there. And yeah, thanks everyone, and have a great rest of the day.